Good afternoon, and thank you for the opportunity to be able to share my presentation on the impact of the pandemic on non-communicable diseases. My name is Nematswerani from Discovery Health. So it's quite important for us to remember that pre-COVID, our focus was really on how to fight the pandemic that was before, which was that of non-communicable diseases. But what happened is that COVID came through, and this is what we saw. There was an intentional postponement and deprioritization of specific services considered less urgent because we wanted to create a capacity for management of COVID. This included, therefore, a deprioritization of screening programs. Because patients feared the exposure of infection when accessing care at healthcare facilities, they ended up not going because they really wanted to minimize interaction with healthcare providers. This meant that some of the services that they could have accessed during this time, they ended up not accessing. We also know that, during this time, it was almost like a collision of two pandemics, the previous pandemic of NCDs with that of COVID. And what we saw was that people who had pre-existing non-communicable diseases, like, for example, cardiovascular disease, diabetes, and cancer, had a higher risk of severe COVID-19 disease and were more likely to die from COVID. The impact of lockdown, social isolation, people have lost lives, lost their loved ones, lost income because some of the businesses could not survive the lockdowns, has had a significant impact on the mental well-being of the population. We've known that from some of the reports that women and the youth have also been, disproportionately impacted by COVID. And there's this specific phenomenon that at the beginning of the pandemic, none of us knew that COVID, which we thought was going to be an acute infection, could end up with long, with what we now refer to as long COVID, with persisting symptoms beyond the acute illness. So long COVID has resulted in, new onset diagnosis of some of the conditions and also, persisting symptoms of the existing, in fact, from the acute illness that the person might have had. I think Victor Tseng, who's a pulmonologist and also a critical care specialist, has tried to articulate the impact of the pandemic in various waves, not the waves that we speak about when we speak about the various infection waves of the COVID infection, but here really speaking about the impact in waves of the pandemic in the long term. And I think he starts by articulating the first wave as that of immediate mortality and morbidity of COVID-19, which is really what we're seeing in terms of the infections and also people getting hospitalized and people dying of COVID. And this also is followed, therefore, by the first wave tail, which is the post-ICU recovery, and this will also include long COVID cases, where people are still going to continue to have some debilitating effects of the acute illness going into the tail of the first wave. And then the second wave is really, the second and third wave really talk about the impact of the resource restrictions on urgent non-COVID conditions, and also the impact of interrupted care on chronic conditions. And I think this is important because it talks to most of what I'm going to be addressing in my slides today. And I think the fourth wave is really something that is of great concern in terms of the impact of COVID, specifically looking at the mental well-being aspects of the population. What we've seen in our discovery data is that, firstly, we look at age and chronic conditions. The risk of being admitted increases the older you are, and also the more chronic conditions one lives with, the higher the likelihood that they'll be admitted. So this is something that's very important. We've seen it in the data, which is why I think if you think about our prioritization for vaccinations, we started with the older age group to protect them. And also now we are thinking about the other vulnerable groups in terms of prioritization. So it means that if you've got hypertension, diabetes, and cholesterol as a combination of conditions, you are more likely to have a worse outcome than somebody who has got maybe one single condition, but even there, it must be well controlled. So we've shown you the admission data in the previous slide. This slide really now emphasizes, the risk from a case fatality point of view, where age still plays a role, and also the number of chronic condition one has also play a significant role in terms of the outcomes when it comes to mortality. What we've also seen are really the benefits of pre-existing health status and engagement on vitality, where we've seen that because of the impact of the lockdowns, people have not been able to exercise as well. The diet has also been not so great, and screenings have significantly reduced. I will share some of the detail in the next coming slides. What we've also seen then is quite an interesting finding that people who were already very much engaged on vitality, they showed very resilient healthy behaviors during COVID, during the lockdowns and the pandemic. So they still continue to exercise, and they exercise even better than their baseline in terms of 2019, and diet in terms of their adherence to healthy foods. We saw an even better increase when we compare to 2019 data, and their screenings also were showing better, in fact, better adherence to screening when we compare to those who were not on vitality. So it just shows that people who were already, very much engaged in vitality during the pandemic, there was actually no reduction in terms of some of these good behaviors. They were actually even better enhanced during COVID. Another important thing, because we know obesity is one of the non-communicable risk factors that we worry about, and we measure this when we do our regular screening. So we measure BMI. So we know that if people are younger in age, and they are obese and overweight, that the risk of poorer outcomes is higher. So obesity becomes an independent risk factor for poor COVID outcomes. And I think we've seen this, and obviously also the chronic conditions. So if you combine then obesity with chronic conditions, you actually see even poorer outcomes. So managing the combination, therefore, of chronic conditions and obesity is important in people who are younger than 50 years of age, to try and make sure that we prevent mortality and morbidity in this age group. We've also seen these long COVID trends beginning to emerge in our data. And I think the most important thing is really to note some of the key categories like diabetes and also cardiac disease, where we're starting to see a 2.75 higher risk of developing diabetes for those people who have had an acute infection with COVID. And also this is even higher for people who are hospitalized. So, I mean, this could be a function of pre-existing diabetes that was undiagnosed, but because people are presenting to healthcare facilities, they start then to be diagnosed with these conditions. Even with cardiac conditions, it's similar, that there's a 1.5 times higher risk of developing cardiac conditions, and also 3.5 higher if hospitalized. So baseline screening rates have already been low during the pre-COVID environment. So if we see reductions, it's reductions of a very low base. So we've also seen in our data that there have been some concerns around now. We're starting to see a shift towards advanced disease, meaning that people are going to have lower survival rates. And when you diagnose cancer later on when you diagnose it later on and when it is advanced, there's a higher cost of care. What are the benefits of cancer screenings? I think if I'm going to just look at the three cancers where there are already existing screening programs. So advanced cancer is not only associated with poorer clinical outcomes, but also with higher healthcare costs, almost 3 times higher than the costs associated with the treatment of early disease. So looking at cervical cancer, we know that if you diagnosed cancer early, your 5-year survival rate for women who are diagnosed early is 93% for those patients, but it is sitting at 15% if you are diagnosed at an advanced stage. This is according to the American Cancer Society. Similarly with breast cancer, delays in breast cancer treatment of more than 3 months have been associated with more advanced disease. And also we see that there are poorer survival rates. If we look at the 5-year survival rate for women with smaller tumors, versus those with higher tumors. So smaller tumors can actually have a survival rate of close to 100% if it is picked up early on. So colorectal cancer, we know that if diagnosed at an early stage before it has spread, there's a good 5-year survival rate of around 90%, and it's much lower if it is picked up much later. So just to give high level in terms of the cancer screening benefits, cervical cancer, we know that for those who are average risk, they can screen with pap smear every 3 years, or if they're high risk, so these are HIV positive patients, they can have their annual screenings. HPV screening, which is another alternative for primary screening, can be also recommended. And for average risk individuals, it's every 5 years, and high risk members, who usually are those who have got HIV, will have a screening recommendation of every 3 years. And this will also include people who have got abnormal pap smears. They may have a higher frequency of screening. Breast cancer, mammography, which usually in our setting will be a combination of mammography and ultrasound. Average risk women can actually be screened every 2 years. High risk, annual screening can be recommended. For some of the high risk individuals, also they can have access to MRI and genetic screening where it is applicable. For colorectal cancer, stool-based test every 2 years. For high risk members, they can have access to colonoscopy. So what we've seen in our data is the decline in oncology registrations during lockdown, which is about a 16% reduction, even though we're seeing a recovery towards the end of the year there. But that backlog in terms of some of the registrations gives us a net reduction in terms of registrations. Similarly, with mammography, we've seen that a reduction of 17% in mammograms. And as you can see, we also see almost like a catch up towards the year, but obviously the average, the net for the year is still lower than the previous years. This is the same thing that we see with cervical cancer screening, where we've seen that 18% drop in the overall pap smears that were done in 2020. So if you compare to the previous years, the net effect is that a reduction, even though we do see that recovery towards the end of the year. Similarly, with colorectal cancer, we've seen some reduction in registrations, which obviously is worrying us, because we know that with the pandemic, people might not have gone for their regular screenings. And here, I mean, the baseline for screening for colorectal cancer much lower. So it is a cancer that we have not really seen traction in terms of the screenings for the eligible population. So which is quite worrisome. So this is early data showing that there seems to be a shift towards more advanced diseases. You can see the stage 2, stage 3 to 4 brackets are starting to increase. So we're monitoring this trend because we're worrying that deferred screenings could result in people getting diagnosed much later, and therefore resulting in more advanced disease and also much more costly conditions to manage. So we worry about growing mental health issues as well, and early indications that productivity gains are leading to burnout. So what we are seeing is that there's been the work from home. We know that people have also been working longer hours. And we know the impact of the pandemic. We spoke about some of the impacts in terms of loss of lives, loss of livelihood, loss of income, loss of loved ones. So there's been quite a significant loss of just social activity. People feel like we no longer are enjoying some of the things that we used to enjoy previously, and this has got significant mental health impacts. And I think there are early signs of an increase in psychosocial visits, and also just the use of psychosocial services. We've seen a 16% actually increase in visits per 1,000 lives for psychologists during this period, but also we're showing you here some of the claimants per 1,000 lives for psychosocial related services. When you compare year on year, that there is an increase, and we're also very concerned sorry, about the younger age group. As you can see, the younger age group in the 20 to 29-year-old bracket. So I think this is an area that we need to be focusing on going forward. And looking at the average estimated weekly extra hours that people have been working, you can see that obviously this will have an impact in terms of people's mental well-being. So home workers are unequivocally working harder, but this may just be a productivity honeymoon ahead of a long-term burnout. And I think this is also very relevant to clinicians, and we've also been running some webinars to this effect. So what are the recommendations, therefore? We think that awareness campaigns to drive NCD screenings, including incentives, are important. Disease management, enrollment, and engagement is critical. Virtual care for ongoing chronic disease support, very critical. And we need to be improving access to NCD screenings and making sure that these are relevant. I mean, they are readily available at various places. And we need to focus on mental health awareness, assessments, and support. And I thank you.